Good afternoon, everybody. I'd like to welcome you. My name is Paul Helft. I'm the director of the Fairbanks Center for Medical Ethics, and we've been sponsoring this lecture series for the past 7 years. And it's my great pleasure to, I'd like to do a couple of housekeeping things first, just to welcome you all. We have guests and colleagues from several locations, including Methodist, Northwest, Arnett, and Saxony. I'd like to welcome all of those. If you all wouldn't mind shutting down your pagers and cell phones or silencing them if you need to have them. And just a reminder that this lecture is being broadcast and recorded. It's my great pleasure to introduce my colleague, Dr. Doug Webb from Indiana University and the School of Medicine. Doug completed his Internal Medicine Residency at Methodist Hospital and his fellowship at IU School of Medicine. He was a physician in the Navy for 4 years and exited the Navy, I think under good terms, right, as a lieutenant commander. He's been active in infectious diseases for 25 years in the Indianapolis community, and he's been the director of infection control and hospital epidemiology for the past 14 years, and provides similar support to the Rehab Hospital of Indiana. I got to know Doug years ago when we were doing some work on pandemic flu planning, and I don't think he would call himself an ethicist, but I was always impressed by how much and how sensitive Doug is to the ethical issues that are inherent in really all the work that we do, but the specific work that he does, much of his own work. And so I'm really looking forward to your lecture, Doug. Thanks a lot for coming.
Well, thank you, Paul. It's an honor to speak here, and it's a timely topic. It's one that we get a chance to talk about frequently these days, one that you'll read about in the newspaper, certainly. The topic that I gave Amy to put on the board was this. Probably the better topic is this, if you like subtitles, is really, is it ethically permissible to do what we're trying to do here at IU Health? And maybe at the end we'll have a discussion about this. I think the questions really are these. The crux of what I'm going to talk about are basically, are influenza vaccines safe and effective? Have current programs really been successful without a mandatory piece? And what do we know about mandatory flu programs, because there actually are a number of these now in the United States. And then lastly, maybe to tease out the ethical issues around this, and we'll go into a little more detail about that. So I know you were looking forward to this, and I knew you'd be disappointed if we didn't get to use some of my old slides that Paul has seen several years ago. But I wanted to at least just briefly review for you some things about influenza, because I think if you don't have that basis, the discussion is a little bit empty. But basically, influenza, there are two relevant kinds of influenza viruses that affect adults, type A and type B. A is the one that usually gets all the press because it is more rapidly changing. It accounts for pandemics. It's the one I think we worry about the most. If you think back in medical school or nursing school, when you learned about influenza, there were surface proteins that really were the important part of the molecule, and there are different kinds of these proteins, H and N proteins. There are 15 of the hemagglutinin subtype proteins that have been identified, only 3 of which have been found to circulate back and forth in human that are transmissible in humans as far as we know. For the N proteins, again, only 2, N1 and N2, that's been found to be transmissible in humans. And that's important because in the other animal population, particularly birds, you can see that birds harbor all of these subtypes, and it really is the major reservoir for any kind of that circulates around the globe. And from that is usually where we get mutations that will change from time to time, and we need to pay attention to these kinds of things. Lots of animals can transmit influenza. Some of these types that we don't contract, but they do pass influenza amongst themselves. There are two concepts that are important as we talk about influenza seasons from year to year. There's drift and shift. The drift are the subtle changes that occur in the strains of influenza A, usually that go from year to year. There's some changes that can occur in B as well. And that is where we target our vaccine to really scrutinize what it is we're going to be seeing the following year, and we gauge our vaccine to deal with those subtle changes in the H and N subcomponents. The antigenic shift is where there's a huge change, where there's a new virus that appears like 2009 human H1N1 that we saw a few years ago. And as we go through time, again, there are usually just 2 or 3 strains or major types of influenza that circulate. This goes up through 2000, but actually we still only have H3N2, H1N1 of the A viruses that are circulating. The virus this year that we all received, hopefully, we got a component of H3N2, we got one of H1N1, and we got a B virus in our vaccine. And so again, as changes occur, that's what we see. And again, usually about January, February, representatives from the World Health Organization, the CDC, and other administrative bodies in the world get together and try to predict what kind of strains are going to be hitting the United States. That's usually based on what's circulating in the Far East at the time, and then our selected strains then go into production for the vaccine and are produced ahead of time. So again, each year there's subtle changes in what the vaccine components are. And then again, as the flu season hits, typically it doesn't hit everywhere all at once. This is an old slide from 2009 where basically the whole country was under widespread influenza activity, but typically it'll seem to start at one of the coasts and then work inland. And in the U.S., it seems like we've got sort of a rule of thumb that I work with the ER folks, that usually when we start to see it on one of the coasts, we'll start to see it in our emergency room within about 3 weeks. And that has seemed to be true in the past. The other thing is that it's seasonal, as we certainly know, and typically, and these are just graphs from Indianapolis from influenza activity, and again, as you see, it will peak weeks 5 through 7 through 9 or so, or about late January, early February in most seasons, except for that one in the red at the tail end, which again was when there was a shift and a new strain, the 2009 H1N1, that appeared, and it actually appeared in the spring and then started to really spread throughout the country in the summer and the fall. Those kinds of shifts, the most famous one was the 1918 pandemic. And we think back, and if you go back to this other slide, that's the H1N1. When it actually first appeared, nobody had any immunity, and it appeared and caused a huge problem, and that's the kind of thing that we sort of worry about and wait for. But in 1918, just to kind of put it in perspective, and these are statistics that are just kind of staggering, but it killed more people in 25 weeks than AIDS has killed in 25 years. It killed more people in a year than the plagues in the Middle Ages killed in a century. 7 times as many people died of influenza during the First World War as opposed to casualties. So this is kind of what we're dealing with now on a regular basis. This was put out by HHS. I guess this is the way they want us to think of this as we go by year to year. But sooner or later, the Grim Reaper is going to fall onto a new strain, and something is going to appear that we're all going to have to worry about and adjust again. And if you remember, and actually this is a slide from when Paul and I were giving talks to the board about worrying about pandemic planning. This was back in, I think, 2008. What we were ready for was H5N1. That was what we referred to as the bird flu, and it still is the bird flu. It still is circulating in the birds, but it hasn't quite made that mutation shift so that the virus is transmissible from human to human. So again, we're really just one mutation away for this strain or some other strains from allowing this kind of a virus to be disseminated throughout the human population and create the kind of havoc that the 1918 influenza pandemic caused. So once again, the other thing about this particular strain, and again, it still is important, and the CDC still does track this, is it's appeared to be very lethal. The red proportion of this bar are the fatal cases of this particular strain in humans, and so it appeared to be very virulent. The other worrisome thing about this was it seemed to be resistant to oseltamivir in many cases, and that accounted for some of these deaths. So again, we in infection control worry about these kinds of things appearing sooner or later, and chances are we will get to deal with this again probably before I retire. So again, just to put this in perspective, influenza is in fact the most common vaccine preventable illness that we deal with in this country. So focusing on a vaccine that can prevent this transmission, I think, is important and appropriate. The burden from influenza is amazing, and maybe this isn't the year to impress this upon you, because we've really had a very mild flu season, probably the mildest that I remember in a long time. But typically each year, about between 5 and 20% of the population, most of these people are unvaccinated, get influenza and become ill. About 200,000 hospitalizations per year. You compare that with other things that we use as benchmarks, it's significant. And again, about 30,000 deaths a year due to influenza, typically affecting mostly the elderly and the very young, but certainly, particularly with the 2009 H1N1 strain, affected young, healthy people in the prime of their life. Worldwide, it's a huge problem. Healthcare expenditures, this is data from 2009. You can imagine what it is 9 years later, but billions of dollars, hundreds of billions of dollars probably. The thing that has seemed to keep this going in healthcare organization is this term presenteeism, where basically you show up to work, you don't get anything done because you feel lousy. Maybe you'll wear a mask, maybe you won't, but basically it's coming to work when you're sick and you happen to spread things around within the hospital. So this presenteeism is a recognized phenomena in healthcare workers, and it's something we try to discourage. Again, just to refresh you, the signs and symptoms, if you've had flu before, you know what it is. I don't have to tell you what it is. Muscle aches, headaches, high fever, abrupt onset. That's the flu. That's not a cold, and typically you'll recognize it. What's important to know is the incubation period. It's very short, 1 to 3 days, and the most important thing about this typical case is that you can shed virus before you develop symptoms. 12 to 24 hours. So let's say you decide not to get the flu vaccine and you're saying, well, as soon as I get sick, I'm not going to come to work. Well, that's great, except the day before you got sick, you probably spread it around to people that were unsuspecting. You can shed virus during the time that you're ill, and I think particularly in immunocompromised patients and in young patients, you can spread it or you can shed it for longer periods of time. Nearly all this spread is person to person. We do think that doorknobs and towels and handshaking and things like that probably have something to do with it, but for the most part it's coughing and sneezing and aerosolizing droplets. There is some work that shows that there probably is some airborne component, but I think the vast majority of the spread is still small droplets from person to person, and when we put somebody in the hospital in isolation, it's in droplet isolation. So the role of the healthcare worker, and I'm inching toward the pertinent part of this talk here, is that the point is that a healthcare worker can be infected with the virus and either be symptomatic or not symptomatic, and can spread it in either situation. But as healthcare workers become infected, I think it's important to know that they not only are infected themselves, but they can infect their family members, they can infect other healthcare workers. They can certainly infect other susceptible patients who may have gotten the vaccine under great intentions, but they're immunocompromised, or they're elderly, or they're very young, and they might not mount a proper immunization response. And so, again, you may spread it to patients, and that's really the main worry. And they often continue to work despite that. Certainly, when people have looked into outbreaks, poor healthcare worker vaccination rates have been one thing that has stood out. So again, it's sort of pointing back to our original problem. So again, you may have a well-meaning AIDS patient that you've taken care of for years that comes into the hospital for some reason. He's gotten his influenza vaccine. He may be telling everybody that comes into his home to wash their hands, to wear a mask if they're sick. He may be doing everything right, and then he comes into our confines within the hospital, and we have a parade of attendings and residents and fellows and medical students, some of which have been vaccinated, some of which have not, and may not be as attentive to those kinds of things as what he is in his own home. Come on, man, I mean, this is the kind of environment that's, out of their control, and we're trying to do the best we can. Come on, man, that's the ESPN bonehead play. Somebody drops the ball. Well, for healthcare workers, this is the bonehead play, to drop the ball. I mean, come on. Anyway, so again, in the healthcare setting, you can transmit it if you're symptomatic or if you're asymptomatic. Nosocomial outbreaks of flu have occurred. The worrisome thing is that, we've seen this occur in NICUs where the mortality rates have been very high. They've occurred among bone marrow transplant patients. And often the healthcare worker is the vector, the one that can be responsible for this spread. So what do we do to prevent it? Certainly everybody needs to be compulsive about washing their hands, about using respiratory etiquette, cover your cough and so forth. Patients, we certainly need to recognize those that might have flu, to get them in isolation and to put a mask on them when they're in the waiting room and those kinds of things. But for healthcare workers, I think it's expected that really we should be doing things that are inherent in our job as we take care of these patients, and we feel that seasonal flu vaccination is one of these. We also try to we also try not to support this presenteeism routine, and try to encourage people that it's okay to stay home if you're ill. So back to the questions. Again, I think influenza vaccines, safe and effective. We haven't answered that yet. In studies that have looked at influenza vaccination, I think it's becoming more and more clear it is a safe and effective vaccine, particularly when it's well matched for the type of strain that we're going to see during the season. Studies that have been done on healthy healthcare workers in the range of 50 to 65 years old, the rates have been 90 to 95% effective in preventing preventing influenza. Frail elderly patients, not as good. These are people that don't seem to mount vaccines responses as well. And in fact, there's a new version of the vaccine which is a higher amount. It does seem to boost the titer greater, but we don't really have good clinical data yet to know whether or not they're protected well or not. There's also data now that shows that these vaccines are effective in preventing hospitalizations. When you compare peers and you compare historical data, it does seem to be more effective at preventing these people from being hospitalized and actually preventing death. And so again, I think there's more and more supporting data the longer we study this. If you look specifically at healthcare workers, again, there's been a documented reduction in healthcare workers becoming sick due to influenza from sick days taken for respiratory illness and from days lost in work. And in fact, there's also an impact on the patients that they care for, particularly in nursing homes where some of this has been seen, but in patient mortality and patient mortality under two separate studies. Is it safe? Well, we think it's pretty safe. We think it's certainly not uncommon to get a local reaction, a sore arm, a red arm, something that would require maybe some ibuprofen or some heat for a day or two. But in terms of severe reactions, allergic reactions, these still seem to be very rare. Yes, there is a potential risk for Guillain-Barré, certainly nothing like several years ago when there was a more of a cluster of Guillain-Barré. These can be a spectrum as well, very mild cases versus a severe case, but it's felt to be a 1 in a million or less. and again seems to be very, very infrequent. The inactivated flu vaccine in particular never causes the flu. It's inactivated. And really the live attenuated strain doesn't cause lower respiratory illness. It may cause a runny nose, on occasion some irritation, but generally does not cause the flu either. So as healthcare workers, as people in infection control that have been promoting influenza vaccine for years and years, there have been a variety of things that we've tried to influence our fellow healthcare workers to take the vaccine. And if you've been around long enough, you can identify with each of these IU Health, Clarion, Methodist plans that we've tried over the years. We've certainly tried education and more education. We've given incentives. We've tried to improve access. You know about the rolling carts, the moving carts, the extended hours for trying to allow people to come. Offering declination forms to tell you why you don't want an influenza vaccine this year. Thank you very much. You'll be amazed at some of the responses that we get. Maybe you won't be amazed, but again, a lot of these things have been tried. Someone put all that together in some published studies to look, in fact, at what the rates were. And for example, for declination, there were 3 studies listed where the rates of vaccination went from 54% to 65%, from 38% to 55%, and so forth. Education, mobile carts, incentives, whistles, gimmicks, balloons, nothing really has worked anywhere near as well as mandatory vaccinating programs. And the first 2 that I think were published were Virginia Mason Health Center and Barnes Jewish, which again got up into the high 90s in terms of compliance. Seeing that, a lot of national organizations trying to look out for the safety of patients felt that, hey, this is a good thing. Mandatory vaccination, maybe this is in fact the way to go. And in fact, almost every major organization now has come out in favor of this, and this just lists a few that we thought were interesting to list. National Patient Safety Foundation, American Academy of Pediatrics, American College of Physicians, or the Internist Group, Infectious Disease Society, and on down the line. Again, I think this has had very, very strong endorsement just in the last 5 years. And in fact, if you think of the lead healthcare organizations in the country trying to look to try to do what's innovative and best for their patients, they've adopted this format of now requiring their healthcare workers to take influenza vaccination. And again, here are a list of a few, and again, a growing number of children's hospitals. And I think all of them have in mind the same general goals of primarily to protect patients. I think first and foremost, it's a patient safety program to try to prevent nosocomial acquisition of flu in their patients. I think the other part of this is that as we move toward accountable care and trying to be responsible for a population of patients, it just seems to be the logical thing to do to try to prevent people from acquiring influenza, knowing that there are 30,000 deaths and 200,000 hospitalizations, that just makes good sense. So in general, we would like to shoot for 100% in these programs. We feel that if we can at least achieve a 90% take in these programs where we have 90% response and our healthcare workers will be at about herd immunity, realizing that there are going to be some people that aren't going to be able to take the vaccine. But we realize too that it really only takes one infected healthcare worker and one vulnerable patient to have a catastrophe. And we've had those in this hospital, at Methodist, and at University that we've each seen in the infection control departments. And it's sad when you see that. So in general, I think the arguments in favor of mandatory vaccines have been listed by various writers, and this is one that listed his litany. Influenza is a serious disease. It's known that healthcare workers can transmit influenza to high-risk patients. There is data that it saves money, that it prevents workplace disruption by having workers not take off as often because of illness. Certainly vaccination's been recommended by the CDC as a standard of care since 1981. Education has had only a modest effect as we looked at that data. We know that immunization requirements, whether it be for MMR, chickenpox, and the like, improve vaccination rates. And a lot of us feel that healthcare workers have an ethical and moral duty to protect our. To add to that list, since this, the Joint Commission has stepped up and proposed a standard of hitting 90% healthcare worker influenza, the measure of quality, starting in 2013. Yeah. 2020. So they maybe the focus of what we were intending to talk about with that background in hand, and hopefully that helps. As you look at what I understand are ethical principles that guide our practice of medicine, would be these four factors. One, beneficence, or the duty to promote good and to act in the best interest of the patient and in a general sense for the health of society. Non-malfeasance, or the duty to do no harm to patients. Our respect for patient autonomy, or our duty to protect and foster a patient's free, uncoerced choices. And then I think ultimately justice, which would be defined here and is defined in the ACP's ethics manual as the equitable distribution of the life-enhancing opportunities offered by healthcare. There was an editorial written by a fellow by the name of Arthur Kaplan from the University of Pennsylvania. This is a center that's affiliated with the Children's Hospital of Philadelphia that I thought was well written and very pointed. And his quotes are that he felt that the interests of the patients for healthcare workers must come ahead of anyone else's. Goes back to the principles we talked about, to first do no harm. But he also had a line in his editorial that I thought was interesting, and he said that healthcare workers have a special duty to protect the vulnerable or who cannot protect themselves. And I think particularly in a children's hospital, we think of this cocooning or protecting these individuals that can't mount an immune response. And we have the same group of patients in adult hospitals as well, and I think that was well put. And the other point that I thought was good was that he felt as healthcare workers we should be providing a role model for the community of trying to teach people what the right course of action is to take. That a lot of people, I think, back off taking influenza vaccines because they see healthcare workers not taking influenza vaccines, and I think they learn from us, and sometimes inappropriately. The other couple lines that he had that I thought were good with my bias was that he felt that the vaccination was a duty that one assumes in becoming a healthcare provider, that this is part of our suit of armor. This is one of the things that we should have on hand. And in conclusion, he said that mandating vaccination is consistent with professional ethics, benefits many, including some who must rely on healthcare workers to protect them, maintains a stable workforce, and sets an example that permits honest engagement with others working in a hospital and with the general public and educating them to do the right thing about vaccinations. So again, I thought that was very well put. So maybe other ways to say this duty to do no harm in some ways would say we should be taking reasonable actions not to put our patients at undue risk. And in some ways, I think not getting vaccinated, allowing yourself to be vulnerable to influenza and then spread it to patients, I think in some ways, I think you can argue that it puts that patient at greater risk. The duty to act in best interest, again, I think taking reasonable steps to try to secure good outcomes, again, trying to prevent them while they're in our facility, while they're ill from something else frequently, to, on top of that, give them influenza. Ethical justification against mandatory influenza vaccine, and I do have at least one slide on that side of things, would be that they certainly limit healthcare workers from making autonomous choices about their own healthcare, the right to accept or refuse medical intervention. It curtails our individual freedoms. That's true. I think that is a valid point. Some would argue, and some have argued, for example, when New York State came out with their edict to have all healthcare workers vaccinated around the time of 2009 outbreak, argue that this is a compulsion, and compulsion is reserved for situations in which people are incapable of making their own decisions, or in which there is an imminent serious danger to others, and many don't consider influenza as a serious danger to others, and I would be quick to argue that. And the other, I think, part of this is you look at these facilities that have adopted mandatory vaccination. I don't think there's any way around this. Mandatory vaccination can be seen as coercive. Invasive, I'm not sure I would say it's invasive, but certainly can be linked to sanctions such as loss of employment if you're not willing to comply with that program. So again, against mandatory vaccination would be, maybe it goes against this duty to be truthful to yourself, that there is certainly an obligation to protect yourself from harm. And I think in the general sense, as these mandated programs have come about, there generally is an out for people that we feel may well be harmed by taking the vaccination if they have an allergy to eggs, if they have a previous history of Guillain-Barré from the vaccine and so forth. So there should be an allowance, I think it's understood, for healthcare workers who are unable to accept the vaccine for those reasons. And then there probably needs to be an allowance for people who have a conscientious objection to the vaccine on religious grounds as well. And I think in virtually every one of these programs that have been in place now, it's generally accepted that they have a religious exemption as well. So to go back to our checklist, I'll answer these. Are influenza vaccinations safe and effective? I think we can show that they are. Have voluntary programs achieved acceptable healthcare worker vaccination coverage? And we would argue no. I think the best that we've ever done at IU Health, I believe, is about 80%. And that was a very good year. Generally, it's not that high. And would a mandatory influenza vaccination policy improve patient safety? Well, again, I think if we can achieve up to the 98% range, I think we could argue that it probably should. Is it ethically acceptable to permit preventable nosocomial spread of influenza from patient to healthcare worker, from healthcare worker to patient, and from healthcare worker to healthcare worker? I think if we're faced with that question, I don't think it is ethically permissible. I don't think we want people coming to work and acquiring the flu here. We don't want patients coming in here to be cared for whatever their problem is and acquiring the flu here. So I would say no, that's not. So I think the last point is, is personal choice of healthcare workers ethically justified over? And again, I think it comes down to this, of the duties to do no harm or to act in the best interest of our patients versus individual freedom or the duties to ourself and the right to autonomy. And I think that is a situation that at times has been sorted out in court. But I think that's where the dilemma is currently. Maybe other ways to put this. If one's not vaccinated and becomes infected and symptomatic, avoiding patients greatly reduces the chance of transmitting the virus to them. But unfortunately, the spread could occur before they become ill, and again, healthcare workers seem to come to work ill, so that doesn't seem to be a solution, just to have a trigger to take off work when you become ill. And then I think the other way to look at this is when an infection that could have been prevented is transmitted to another person, we would consider that as harm if it's preventable. If somebody develops a catastrophe from surgery that we feel that was fully preventable, we would consider that as potential harm. And so again, I think in the same context, if we've got an opportunity to prevent these kinds of things, I think it's our duty to try to prevent them. Maybe other ways to phrase this autonomy is that the person has a right to make his or her own decisions and choices in regards to his or her own body once fully informed of the situation. And I think that's true, but there can be an impact within the environment where they serve, where they work, and it's not quite as simple as that all the time. One could argue that if a patient has a right to refuse vaccination, doesn't the same privilege apply to healthcare workers? Well, maybe, but if you're working in our hospital with our immunocompromised patients, maybe not. And again, I think this lends itself to potential legal challenges. So again, I think these organizations that have decided that mandatory vaccination programs for flu have been the right thing for their organization to do, I think fully understand that there could be some legal challenges ahead. I think one other point just to throw in would be justice, and interestingly, there's a very articulate article written by a PA that pointed out these items. There, as we alluded to before, there is data to show cost savings when there's been good acceptance of influenza vaccine. People have estimated in this English study that $150 per person were saved in preventing influenza among healthcare workers. We worry about staff shortages without having good influenza vaccination. The wording he has here is healthcare workers who do not take reasonable and prudent steps to avoid being vectors of nosocomial infections are acting in bad faith to the ethos of healthcare and disrupt the milieu of trust that should prevail. And I think that's well put. And I think his point was that given all that, there still should be some exemptions granted for individuals that can't take the vaccine. So just to give you kind of an overview, and I'm just trying to wind up here, and if we can have discussion, that's great. These, I think, are the first three major healthcare systems that published data on implementing a mandatory influenza vaccination program. Virginia Mason out in Seattle really was the trailblazer. They have about 5,000 healthcare workers that they are responsible for. In 2005 was their first year of mandating influenza vaccination. They actually had a compliance rate of about 97%. And they have consistently had greater than 98% since then, extending past the published time as we see these people come to our conferences. And they have a very successful program. Barnes Jewish in St. Louis, again, a larger program, 26,000 healthcare workers. In that program, the University of Washington School of Medicine declined to be a part of that. Their physicians are not part of that were mandated. As we talk to them, they're still trying to accomplish that and include their physicians. Their physicians have a fairly good vaccination rate in the 80% range as we understand it, but they're not required, not mandated yet. But again, they have achieved over a 98% compliance rate with vaccination. And MedStar, which is a conglomerate of about, I think, 11 different hospitals in the Baltimore, Maryland area, responsible for 29,000 healthcare workers, including 4,000 physicians. They also had about a 98.5% compliance rate. So again, I think these programs are out there. There are actually, I think, in the 100 now, over 100 programs around the country that have mandated influenza vaccination. And from what we can understand from data that we see, it seems to be a very successful programs. There are individuals that do get exemptions out of these programs for religious or medical reasons. There are employees that have decided to not continue to work at these locations and have left work because of that. But in general, those numbers have been very small. Small numbers of medical exemptions, small numbers of religious exemptions, smaller, and really usually just a handful of people that have decided not to work there. So given all of that, and the reason we're here today, is many of us have felt that, again, this was a good thing for our patients to consider and have been talking about it for the past couple of years and have now reached the point where we're in the process of implementing it. So this, I think, just the bare bones facts about the IU Health system-wide vaccination program. The plan is that it will be executed at the facility level through facility leadership, that all healthcare workers, including physicians with practice privileges, will be immunized by a given date, December 15th, that the vaccine would be available, usually starts when the vaccine's available, about September, and that medical and religious exemptions will be considered. You need to submit approval for that, as what has been handled in these other large programs, and they will be reviewed by a group of individuals. In fact, because of our interest in this and other hospitals in the area's interest in this, particularly St. Francis that made their system mandatory this year, there was a workforce established and a charter through the Indianapolis Patient Safety Coalition to try to get all healthcare systems in the Indianapolis area to come on board with the same philosophy of trying to protect patients by immunizing healthcare workers and include a mandatory program for vaccinating. And that, in fact, is in the works, in place. I personally have met with all of the chief medical officers at these hospitals. Lori Fish, in the second row here, our executive director for infection control, actually is the chairman of that committee. We meet monthly. We've had a lot of good discussions, and I think, again, we're working toward all of these hospitals in the Indianapolis area, including many of the donut beltway hospitals, coming on board with this as well. Early successes, what do we know so far in this area? Again, IURNet chose to move ahead this year and have actually had a mandatory program in place that was extremely successful. The data from Deb Gregory, their infection control practitioner, showed that they had 99.7% compliance, that they actually only lost 4 individuals who decided that they wouldn't get the vaccine, and there were 5 exemptions granted between medical and religious. The St. Francis and St. Elizabeth in the Franciscan system that we had data for, again, showed extremely good compliance, 98 and 99% for these local hospitals. What we don't have is data on how it impacts nosocomial spread and nosocomial infections, and that's something that I think is going to be a valuable piece for all of these healthcare systems that have in place to show that, in fact, the point of the whole program is actually helping. I mean, again, I think we've got some data, but we probably don't have the best data that we would like to have. So in conclusion, this is a biased ethical discussion because we've been in charge of trying to get this going, because in our minds, ethically, we think it's the right thing to do. But clearly there is another side, and we've had pushback from some individuals along the way. And I think there certainly are articles in the literature that would argue that a mandatory program maybe isn't the best way to go. And I would agree with that. But we can't seem to get any better results without going mandatory. So if in fact there was an incentive that worked, if we could get a car dealership to give you a car for getting a vaccine, great, we won't mandate it, but we don't have the kind of incentives that I think make an impact here. So I would open it up to questions, and we'll take the darts. Yes.
My name is Dave Ellsworth. I'm with the State Health Department, the immunization program pastor at the State Immunization Program in the 90s. And I want to support everything that I've heard today. And if you can't win the ethical argument, your third bullet point on one was cost. I'll share a story with you. In the 90s, there was, if you recall, there was a measles outbreak in Lafayette, the largest at that time, the largest measles outbreak since the 89 measles, 37 cases. Two of those individuals ended up in one of the Lafayette hospitals, one on a ventilator and one not quite that sick. The story that I want to share with you is our agency and the CDC wanted the hospital to prove immunity for the employees because two were in the hospital. They couldn't do that. They did not have computerized records. It cost them $64,000 in IG, 1,500 employees, and it relates to your comment about disruption of work and cost. They didn't need that problem, but they got it and they dealt with it. But it was just part of the whole measles outbreak that occurred. A couple other points I might make. I do disease investigations now. I stepped down from the directorship, and I work with the clinics now in 14 counties, I think it is. Part of our Vaccines for Children program, each clinic has to be audited once a year. And one of the questions on the CDC data that we have in our laptops and we ask the practitioners is which of these vaccines are required to work here. We rarely see anyone say this one, or this one. Arnett is in my region, and as the slide shows, Francisco and I have some of those. They are now, as of this year, getting that done. But your private doctor's offices and many other, quote, other private public clinics, they're not there yet. So hopefully that will also, this concept will stretch further than the hospitals and start getting out into those private clinics and private physician offices.
Questions? Or did you have a question, or did you just want to make those comments?
He was a plant, but I'll deny that.
I figured.
Thank you.
Thank you.
So by getting the flu shot, I won't get the flu.
Well, I'd like to be able to tell you that, but I think your chances are much greater that you won't get the flu if you get the flu shot. It's not 100%. Yes.
I agree with you that healthcare workers coming to work when they're sick is a very big problem. But I would suspect that healthcare workers who work in a system that allocates actual sick time over just a generalized PTO, I would think that would be greatly reduced. Do you have an opinion on that?
It's hard to track data, and we'd like to know how something like this would affect sick days, but as I understand it, we're not allowed to ask or know why people use their PTO days.
Well, I've had many conversations over the years with people who are clearly sick, and one of the common responses I get is, I can't afford the PTO. Right. I don't want to take the PTO.
Right.
So it just stands to reason to me that if people had an actual sick day bank that was not affected by their PTO, that a lot more people who are sick would stay home. And I think that to me seems.
I think we can ask the question, and because this is not about just vaccination, it's about an overall and we'll follow up on it.
Betty, just a comment, because if I understand your point well, which I appreciate, that people in the sort of lower socioeconomic strata of our organization are much more vulnerable to PTO-related issues. On the other hand, one of the arguments would be that they're less likely to get the flu and therefore not have to take PTO. So I just wanted to mention the other side of your argument, which I do appreciate. Yeah. Other questions or comments?
Do we have any data yet from this past year because it wasn't mandatory, but you did have to fill out a declination form if you didn't get it. So do we know how that affected the numbers so far? Or?
Yeah, it did budget's not.
I think it actually was less than the previous year. I think we were down around. Do we have any data on this year? This year was not mandatory, but it was mandatory for either filing a declination or getting the vaccine. And in fact, as I remember, the numbers were less for the academic health center. I think we were 80% the year before, and I think we were 70. 65. System-wide, I think we're actually a little better than that, weren't we?
We were at
70, that's what I remember.
Larry? And then Tim.
I'm guessing this is going to track with the general population, but is the hospital or the system tracking adverse effects from the vaccinations?
Can you just repeat that?
Are we tracking adverse effects from the vaccination? It certainly is incumbent upon us to do that. We do have some data. We don't have as detailed a data as I think we should, but certainly if we implement a program, that is going to be absolutely part of it, yes.
Tim.
I'm one of the chaplains here. I was curious what constitutes a religious objection that would be valid. I know like Jehovah's Witnesses have a long-standing theological tradition about blood and that. But I also know that like in some evangelical Christian communities, there's this, panic that, don't get your kids vaccinated because, it causes autism or whatever. I don't see that as a real valid religious objection. I'm just curious of what the hospital's stance on that would be.
Can you briefly summarize?
He was asking about what will be the basis for deciding whether someone gets a religious exemption or not. I would say of all the issues that we would talk about potentially, that's probably the most controversial. And it's interesting in the large healthcare systems that have published data, in general, there are just a very, very small handful of individuals that end up getting religious exemptions. And I think we've seen that too at Arnett and within the St. Francis system. The plan, there's actually a fairly large work group that has been formed system-wide to try to draft the policy and come up with a form for religious and medical exemptions and a flowchart on how to handle all that. Some of this is still being worked out, but I think learning from other large systems, it would be that they have a genuinely based belief that is against their recognized religious system that they adhere to. And I think teasing that out sometimes is going to be the difficult part because people don't want to get shot. There are some people that just don't want to get shots, and they're going to look for any way around it. And I agree with you that I'm somewhat distrustful of what we might see potentially, but there clearly may well be people that have a deeply held belief that is not the right thing to do, despite the fact that they chose healthcare for their profession. So that's hard for me to understand anyway. But I think to try to honor that value, I think we will try to evaluate these as best we can. Lori, you want to?
I was going to say a lot of the religious exemption is based on the law and equal opportunity law, so that it was really a legal decision that we had to have a process to accept a deeply held religious conviction. We have a team of someone from the ethics committee, that will be reviewing on a case-by-case basis. And there isn't any real criteria other than it needs to be a deeply held conviction about a religious belief. And so we'll just work through that on a case-by-case basis.
Tim, you used the sticky word valid religious objection. I thought that was interesting. One question here, and then Father, and then somebody had their hand up here. Okay.
I just had a quick question, Doug. What's the influenza vaccination rate in general for the population? Maybe it was on one of your early slides. And secondly, do we track it in terms of patients who are in the IU health system for primary care for adults and children?
I don't know that I've got any of that data. I think for healthcare workers nationally, it was around 45%, something like that. And I think for the general population I think is relatively low, in the same range, if I remember right. And for IU Health, in our primary care clinics, I think we are tracking that now for IU Health system, but I don't know those numbers.
How does this discussion change in the future if the practices by which the vaccines are developed are changed? Specifically, I ask because today the vaccines are cultured on chick embryo and things like that. There have been a couple of applications to the CDC to use fetal cells for flu vaccines that have all been rejected so far. And there hasn't been any in several years. But if we get 4, 6, 10 years down the line and the CDC approves that, is it going to be incumbent upon the hospitals and health systems that are asking for these mandatory vaccinations to provide a two-tier, you can either take this vaccine or this vaccine, or to change to a philosophical exemption as opposed to specifically a religious exemption?
That's a nice, simple question for you.
Well, but
I like that. Straightforward.
But I think we have an answer. In conjunction with pandemic flu planning, a lot of effort has gone into technology for development of vaccines, and particularly for trying to look for alternatives of cell-based vaccine systems. And in fact, I believe that there is a non-egg, non-cell-based vaccine that's currently being used in Europe that there has been talk about implementing in the United States, but I don't think they've overcome the hurdles yet. So I think the answer is on the way. So those individuals that have egg allergies, for example, I think that would wipe those people out of the exemption class then. And I suspect the FDA is just watching for results and outcomes and side effects from that. But I think the focus has been to try to get away from developing vaccines using eggs.
How does the CDC come up with the estimated number of deaths per year? Since we don't routinely screen for flu, how do they get that number?
Well, off the top of my head, I don't know that I can tell you. Yeah.
Okay. So the patient would have been screened and had a documented influenza A infection, and that would have been
I would guess it's frequently listed as the 6th most common cause of death in the United States. And I think that's taking into account all the complications, including bacterial pneumonia and respiratory failure and that sort of thing. So I would guess it's probably death certificate. I think that would probably be the only valid way. Certainly it's not microbiologic or, I probably should have thought about that before I presented this talk. But
was there an underlying question there, though?
Well, I was just curious how,
Okay.
Because I'm just thinking we don't typically screen anybody that comes in with just pneumonia or whatever. We're not always looking for that. So how would they come up
And
with
death
that?
certificates are not 100%
And
accurate.
Right.
To say the least. Is there another hand up that we missed?
I was going to ask, can you get the flu from the flu shot?
I'm glad you asked that. No. The main flu shot that we use is the inactivated shot, and that's the one that 98% 8% of people are going to be receiving. And it's a killed virus, so no, you can't. Now, clearly, I mean, people can have mild side effects from the shot itself, but it wouldn't be the flu. And people, may get the flu shot at a time where they just acquired influenza. So there's always that association, or they may have another respiratory virus. But technically, no, it just is impossible to get it from a killed virus. I think the live attenuated, yes, you can have some nasal congestion, some irritation, runny nose, and that sort of thing from it. But again, it's not the flu. It can't, those cells that they use can't, or those viruses don't seem to be able to infect the lower respiratory tract. So you shouldn't be able to get the flu from that either.
Just a quick straw poll, how many of you have ever gotten sick from the flu vaccine? Who got either the flu or something else? Do you feel like you did? Okay. My aunt says she always gets the flu when she gets the flu vaccine.
I need to talk to her.
Yeah, you need to talk to my aunt. That's right. Right. I always get the flu afterwards, which is interesting. Betty, were you raising your hand? Because if not, it's 1 o'clock, and I think we've well, I don't want to say we've terminated, but we've. Thanks a lot, Mike.